you know in your anatomy classes that meninges has three layers. The meninges has to protect the brain from the outside trauma. So there are three protective layers in the brain, and this also covers the spinal cord. So it is the outermost layer, you know, it is a dura mater. Hey, okay, why you are talking? Please stop. Please stop talking. Pay attention to the class. So meninges has three protective layers from outside inwards. This is dura mater, arachnoid mater, and pia. Watch these things. Talking will not give you anything. You watch this thing and try to learn. Meninges has three protective layers. Meninges is the protective layer of the brain. It has three layers from outside inwards. It is dura mater, which is in contact with the skull, and there is the pia mater, and inner layer is the middle layer is the arachnoid mater. Inner layer is the pia mater, which is in contact with the surface of the brain. So you know all these things. So this arachnoid mater is the middle layer of the brain. This is called subarachnoid space. So subarachnoid space is the space between the pia mater and the arachnoid mater. CSF pia mater is the innermost layer. Epidural, there are, in our previous classes we discussed about several hemorrhages like epidural hemorrhage, subdural hemorrhage, etc. So what is the epidural space? Is the space between the dura mater and the bone, and subdural space is the space between the dura mater and the arachnoid mater. And CSF is below the subarachnoid space. It contains CSF. There are two innermost layers together called leptomeninges. CSF, you know, it is a cerebrospinal fluid. It is almost a clear fluid running between this cerebrospinal space in the brain and also in the spinal cord. This is a clear fluid, contain normally 5 WBCs per cubic millimeter. 70% of them are lymphocytes, 30% are monocytes. The very few cells, only 5 cells per normally, and few neutrophils. Also contain protein. What is the composition of CSF? It contains protein 15 to 50 milligram per dl. It contains glucose. Normal level is 45 to 100 milligram, maximum 100 milligram per dl. Normal CSF pressure is 200 millimeter of H2O, or it is 20 centimeter of water, or 15 millimeter of, it is not Hg, it is not mercury, it is written wrong, it is not mercury, it is a 15 millimeter of CSF, it is not mercury, please, sorry for the mistake, 15 millimeter of CSF, cerebrospinal fluid, not mercury. So what is the blood-brain barrier? You know that a permeability barrier that separates blood from the brain, extracellular fluid and CSF, formed by tight capillary endothelial cells. You know there are arachnoid villi. In the arachnoid villi, in the subarachnoid space, there is this in the and it produces CSF. That is a CSF, and that CSF produces the pressure, and CSF also in constant circulation. It is also is constantly changing. It is reabsorbed and again resecreted by the arachnoid villi. It is from a tight capillary endothelial cells. So any materials to enter into the CSF or brain parenchyma will have to go through this blood-brain barrier. So it produces endothelial cells, produces a blood-brain barrier. Everything you give cannot enter into the CSF brain parenchyma. It is disturbed in condition like meningitis, trauma, or brain tumor. In these conditions, this blood-brain barrier will breach, and those materials which was not entering due to this blood-brain barrier can enter if there is a meningitis or there is a trauma in the brain, or there is a brain tumor. So this is there. What is meningitis? By definition, meningitis is the inflammation of the leptomeninges. I have already discussed what leptomeninges is. The inner two layers, this pia and arachnoid, they together called leptomeninges. So meningitis is the inflammation of the leptomeninges, the inner two layers of the meninges covering the brain and the spinal cord. What is encephalitis? Encephalitis is the infection of the brain parenchyma. And when occurs together, it is called meningitis. So this part is clear. Meninges is an infection. When the infection is confined to the meninges only, we call it meningitis. When it is spread to the parenchyma, underlying parenchyma of the brain, we call encephalitis. Together we call meningoencephalitis. Only if there is only meningitis, patient will have this neck rigidity and fever, etc. But when there is involvement of encephalitis, there will be convulsion. Convulsion is a sign of encephalitis, or there is a space occupying lesion. But meningitis per se, when it is confined to the meninges, it will not cause this convulsion. And convulsion, why convulsion occurs? Convulsion means there is a involvement of the cortical cells, or you can know it is a beige cells or cortical cells. When there is by any conditions, any pathological conditions, to give rise to seizure or convulsion, it will have to involve the cortical layer or the beige cells. And inside the parenchyma, if there is a space occupying lesion, it can compress the underlying the nearby structures. That is a space occupying lesion can compress the nearby structures. These two are the signs of encephalitis. But meninges per se will not produce this seizure or space occupying lesion. So, what are the important causes? Causes of this meningitis are most commonly they are bacterial. Infection is the most common cause. May be caused by bacteria. The bacterial is the commonest cause of this. Several bacteria can cause this. Group B Streptococcus, E. coli, Neisseria meningitis, Listeria, and Pneumococcus. In elderly people, the pneumococcus may be the commonest cause. Listeria and gram-negative bacilli. Like bacteria, some viruses may also cause meningitis, like enterovirus. Enterovirus, Coxsackie and Ecovirus. This Coxsackie virus and Ecovirus. These are the enteroviruses. And herpes simplex virus, HSV, very important cause of herpes simplex virus 1 and 2. And varicella zoster virus, the virus, chickenpox virus that causes varicella zoster, that can cause also meningitis. And mumps and HIV. Mumps and HIV. Then other than bacteria and viruses, fungus may also cause meningitis not in immune competent host, but in immune compromised host. Like what are the immune compromised state? What are the immune compromised state? HIV is the immune compromised state. Good. Any other? Patient, any cancer patient is immune compromised state. Any patient getting anti-cancer therapy, they are also in immune compromised state. Patient taking monoclonal antibody. Several monoclonal antibodies are used in several diseases nowadays. So patient receiving monoclonal antibodies, they are in an immune compromised state. And nowadays, diabetes is also considered as an immune compromised state. So these are all immune compromised states. So cancer patient getting anti-cancer drug, there is a monoclonal antibody, and this HIV, definitely HIV, and these are the immune compromised state. So this immune compromised state can get these infections, these fungal infections, mainly Streptococcus are the fungal. Other than fungal, there are some tick-borne diseases like Borrelia causes Lyme disease. In some part of the world, Lyme disease is the commonest cause of meningitis. In this part of the world, infection is the commonest cause. Pneumococcus and meningococcus. You will get it most common causes. And next, another is herpes virus infections. These three diseases will almost complete the 90% of your meningitis patient. Pneumococcus, meningococcus, and herpes simplex. These three things. And in this part of the world, also we must learn about tuberculosis. And SLE also causes meningitis. This will come later. So these are the common causes you will face in your wards. Why this meningitis occurs. This thing. So fungal infections are an HIV patient, of course, cryptococcal meningitis is also very common in HIV patients. So the spread of organism in the CSF is how this organism spread. I have already told you that the organism after entering blood, it will not enter into the, it cannot enter into the brain or meninges unless it breaches the blood-brain barrier. So blood-brain barrier can be breached by these conditions. Either there is a direct trauma like skull fracture or spina bifida. Spina bifida is a disease, there is a diverification of the spine of the spinal cord, and this is vertebra, and this is a congenital anomaly, and the spinal, the underlying spinal cord is exposed. This is called spina bifida. Here it is there can be a direct spread of the bacteria to the meninges, or other than this, skull fracture trauma or up through. Yes, and the most common way of spreading is from the commensals bacteria in the nasopharynx. There are several commensals bacteria. What are commensals bacteria? They are lying in the mucous membrane. They are not breaching. They do not cause any harm. Rather, some of the commensals are doing good to the body, but not doing harm. But they are staying there. This is the commonest way of spreading. These are organisms in the upper nose that could spread into the meninges. That is a common way of spreading. Then or there may be hematogenous spread reaching the blood-brain barrier. So there is a direct spread, or from the nasopharynx it can directly involve the meninges, or through the blood it can breach the blood-brain barrier. It has to breach the blood-brain barrier to reach to the underlying brain. So what is subacute meningitis? The acute meningitis, I have told you, usually is a very stormy events. Patient comes with a high fever, meningeal irritation, photophobia, vomiting, etc. And within 48 hours, everything developed. But subacute meningitis, it takes about weeks. Persist, depending on the organism. The meningitis may be very acute, like pneumococcus and easy ray meningitis, herpes simplex. They are very causing stormy events. Everything within 48 hours. But it may last up to weeks, depending on the organism. And chronic meningitis symptoms persist for more than 4 weeks. When symptom persists more than 4 weeks, we call it a chronic meningitis. Most common chronic meningitis in our India is not in India but Southeast Asia, is a tuberculous meningitis. It's very common. Tubercular meningitis. You will see if you go in your internship period, you will see many cases of tuberculous meningitis in the board. Very common. So meningitis, I have already told you what are the symptoms of meningitis. There is a fever, there is a headache, there is altered sensorium. Altered sensorium, the sensorium is altered. There are very important questions for the examiners in your exam is, tell some causes of fever with altered sensorium. Prepare for these questions. Fever with altered sensorium. Not only meningitis, fever with altered sensorium comes many things, malaria, dengue, all this comes in the fever with altered sensorium. These things. So fever, headache, and altered sensorium, and there is a neck stiffness, and there is a and I have already told you, if the encephalitis or the brain parenchyma is involved, there will be seizure, and also there is focal neurodeficit. Features of TB meningitis, especially I am mentioning this TB meningitis because it is very common in our country. So there is a features of TB meningitis. You show this all signs of meningitis are there, like fever, like headache, photophobia, and vomiting. These are, you can get in any meningitis, and tuberculous meningitis also. And altered sensorium, it can also occur in tuberculous meningitis, and of course it is a chronic process. I have told you it is a chronic meningitis, lasts for more than 4 weeks. And in addition to that, there are cranial nerve palsies and hydrocephalus. What is cranial? Because you know, every cranial nerve has to pierce the meninges to come out of the brain, except optic nerve. Optic nerve do not pierce the meninges because the optic nerve goes along with the meninges into the brain. So it does not pierce. But other than second nerve, all cranial nerves has to pierce the meninges to come out of the brain. It pierces at different, depending on the site of the cranial nerve, it pierces in at a different position of the meninges. But when it pierces the meninges, if the meninges is infected, and if it is a chronic infection, it can cut the cranial nerve. So any cranial nerve any cranial nerve can be involved in tuberculous meningitis except optic nerve, because all nerve pierces the meninges, and particularly even in your practical experience you will see when you start the treatment for tuberculosis. They are very common in when you start the treatment for tuberculosis. Suppose there is a tubercular meningitis, you have diagnosed it by doing your CSF and everything test you have done, you have started treatment. After starting treatment, it is very common, because when you start treatment, the fibrosis is more. There is healing. Healing causes fibrosis, and there is fibrosis of meninges. They catch the cranial nerve into that fibrosis, and cranial nerve's involvement is common during. It can occur during tuberculous meningitis, or very commonly it can occur after the treatment is started also. So you can be in a mess. What happening? We have started the treatment of tuberculosis. Now the patient is coming with a fourth nerve palsy or third nerve palsy. How it occurs? It can occur because of the fibrosis of the meninges. Anyway, so and hydrocephalus is same. The hydrocephalus is same. You know when there is two type of normal. There is hydrocephalus in the foramen of Monro. You know where the fourth ventricle meets with the spinal cord. Is the foramen of Monro. It is called that the foramen can be constricted due to fibrosis. That can causes dilatation of the ventricles. So this ventricles and cerebral ventricles containing CSF. That dilatation can cause hydrocephalus. This is also a complications which can come after starting treatment. Patient developed hydrocephalus. Patient was in an altered sensorium state. You have diagnosed the case of tubercular meningitis. You have started the treatment, but patient again the sensorium of the patient is deteriorating. Then you suspect the patient may have hydrocephalus. Tuberculous meningitis patient have started treatment, patient should improve, but patient is deteriorating until their sensorium is not improving. That gives rise to a suspicion the patient might have developed hydrocephalus. You do a CT scan and see the sizes of the ventricles, the cerebral ventricles. You will see they are dilated. This is hydrocephalus. Now, other than infections, there are other causes of meningitis also, like acute autoimmune disorder like SLE. I have told you SLE. SLE is the important cause of meningitis. Causes then there is infections, no organism is involved, but there is meningitis, and there is carcinomatous meningitis. There is diffuse anywhere a carcinoma in some part of the body, but it is spread along the meninges. That can carcinomatous meningitis. The non-bacterial causes, non-infective causes. And also neurosarcoidosis. Sarcoidosis, you know, one disease which causes granuloma formations, and this can involve in meninges also, can cause meningitis. These are the causes of non-infectious causes of meningitis. Now these things this is important for word practices, that this is the the word Kernig sign and Brudzinski sign. These are positives in meningitis patients. And in the right hand side, it has been written what I have told till now, all the symptoms like fever, headache, neck stiffness, altered mental status, photophobia, nausea, vomiting, and seizures. Seizures sometimes means when there is encephalopathy, and the classic triad is fever, neck stiffness, and altered sensorium. How the neck stiffness is tested, you know, the neck is uplifted, and there is you cannot flex it properly, and it cannot be it is not freely movable side by side also. That is neck stiffness, that you know. But these two special tests you will have to do in connection with the meningitis is Kernig sign and Brudzinski sign. Kernig sign, you saw the leg is lifted like this 90 degree, and the foot end of the left is you are trying to further extend it. Then you cannot do it. You can't do it up to this level. If you hold the ankle of this left leg and try to straightening it, you cannot straighten it. That is the Kernig sign. And Brudzinski sign, what is this? If you flex the head, then the knee and the hip will be flexed. You are standing at the head end of the patient, and you are flexing the head forcefully, slightly forcefully. Then there will be flexion of the knee and the flexion of the hip. That is called the Brudzinski sign. These two signs are important clinical findings in connection with the meningitis. Now it is a little elaborately discussed about the causes. Bacterial meningitis most common, I have told you, it is a Streptococcus pneumoniae. The pneumococcus is the commonest cause of organism, commonest organism causing meningitis, bacterial meningitis. And of course, next is Neisseria meningitis. These two important causes I know you'll have to know. Very important. Pneumococcus and meningococcus. You'll have to know. That's why I have discussed this in a separate slide. Most common is Streptococcus pneumoniae. Common sources are I have already told you nasopharynx. It is a common normal commensals in the nasopharynx. And also in the otitis media, if the patient is suffering from otitis media, there is sometimes either a cochlear transplant. Some deafness cases, particularly in children, the ENT surgeons put a cochlear transplant. That is a source of infections, sometimes causing meningitis. And of course, splenectomy. Splenectomy, following splenectomy, if the spleen is removed from the body, in several conditions, spleen is removed. If there is a trauma, the splenic hemorrhage, spleen is removed. But an important cause of splenectomy is, in our medicine word, is hemolytic anemia. Hemolytic anemia. Try to always remember it. The commonest meningitis, why you do the splenectomy in the medicine patients? Common hemolytic anemia, particularly thalassemia. And thalassemia is the most common hemolytic disease that causes splenomegaly. But one hemolytic anemia do not cause splenomegaly. Very important. Is sickle cell anemia. Sickle cell anemia is a hemolytic disease, but do not cause splenectomy because it causes microinfarct, and spleen is gone by microinfarct and fibrosis. Spleen is actually this smaller in size and it is not palpable in sickle cell anemia. But other hemolytic anemias, particularly in thalassemia, as it is very common, there is spleen is hugely enlarged. Sometimes it is hugely enlarged. So we sometimes do a splenectomy in thalassemia patient. If you do a splenectomy, following splenectomy, pneumococcal infection is an important infection patient might have, because if you do a splenectomy, it will also putting the patient in some amount of immune compromise. The spleen is a very important immune organism to protect the immune. So if you do the splenectomy, patient, you are some way you are suffering the patient for the immune. Some patient is immune compromised, becomes immune compromised, but you have to do it because spleen is a eating bloods. In thalassemia patient, what you call is hypersplenism. Hypersplenism is a condition where spleen is eating bloods. Spleen actually, the function of the spleen is to produce blood. But in huge splenectomy and in disease condition, it starts eating blood. It eats all. It eats RBC, it eats leukocytes, and eats platelets also. So it eats all types of bloods eating. This is a massive splenomegaly. When it starts eating blood, we call it a hypersplenism. Hypersplenism. Hypersplenism is the condition where it do a splenectomy. This splenectomy can compromise this patient for immune compromise, and patient may get a pneumococcal infection. So it is a must. Following splenectomy, we should give the patient a pneumococcal vaccine. Pneumococcal vaccine is a must following splenectomy, so that the patient do not have this capsulated organism. Capsulated, they are exposed to capsulated bacteria, particularly pneumococcus. And in our example, catch question is, which causes pancytopenia? You know what causes pancytopenia? Pancytopenia means all the series of the blood is diminishing. It diminishes RBC causing anemia, it diminishes leukocyte causing neutropenia, and it diminishing platelets causing thrombocytopenia. All these series are decreasing in the blood. Patient usually presents with anemia or recurrent infections, or due to platelet reduction of platelet, they can present as a hemorrhagic manifestations. So there are two important causes of all the three series of blood is diminishing. Either it is not producing from the bone marrow, which is called as hypoplastic or aplastic anemia. Hypoplastic or aplastic anemia. And another cause of this, all the three series are decreasing, are hypersplenism. This spleen is enlarged. Now, I have told you eating all the bloods or blood cells. So these are two important causes of pancytopenia. This bone marrow fibrosis, or there is bone marrow aplasia, and there is hypersplenism. Anyway, they are very exposed to pneumococcal infections. We do a splenectomy. These are bacterial management. The symptoms are severe headache, high fever, early sepsis. This pneumococcus is very notorious for doing early sepsis. Sepsis means the organism from the brain comes to the blood, and it is proliferating in the blood. That is called sepsis. And meningoencephalitis, I have already told you, common. And this meningitis, pneumococcal meningitis, quickly turns into meningoencephalitis. That it involves the brain parenchyma and causing seizure also. So it quickly involves the brain parenchyma in seizure. So encephalitis, and there is leukocytosis and high C-reactive proteins. This occurs in any bacterial infections. There is high leukocyte count and there is increased C-reactive protein. CRP means C-reactive protein. Now, the most important cause for examination purpose and for your interest also, very interesting infections is Neisseria meningitis. Neisseria meningitis is an important cause of infections for your examination purpose, because these are the some unique features unrelated to infections. Because it alters the immune status of the patient. Which usually pneumococcus do not. But this Neisseria meningitis, they alter the immune status of the patient. That's why many interesting features comes in the patients. So there is all the pathology classes, there is a gram-negative Streptococcus capsulated, produces endotoxins. How it spread? It is spread from a crowded environment, from a military barrack. Suppose one military has got the meningococcus, other soldiers may catch these infections. This is a crowded environment, is an important cause of this spreading of this meningitis. Another important is complement deficiency. Complement, C5, C3, say this complement 5 and complement 3. The complements, they are what are the role of complements in infections? They actually, complements are opsonize the bacteria. Opsonize, the term by means the bacteria becomes palatable to your defense cells, like your lymphocytes. So it is opsonize. Opsonize complement. Why they are in response to infections? There is production of complement. What the complement do? Complement put a layer along the bacteria so that it becomes palatable to the lymphocytes. It can be taken as palatable. Means the lymphocytes takes the bacteria because it is tasty. It turns the bacteria and tasty to the lymphocytes. This is opsonization. Very simple words. So this complement is produced into infections to opsonize the bacteria so that the lymphocyte could take it easily. So this, but if this complement is reduced, naturally the bacteria will not be palatable to the lymphocytes, and thus there is chance that bacteria is getting chance to spread the infections. So this complement deficiency is the important factor for this Neisseria meningitis. And of course splenectomy, I have told you why this splenectomy causes patients exposed to infections. Skin rashes, this important, this Neisseria meningitis, I have told you this endotoxins. The endotoxins causes some immunological changes. This immunological changes you can see in the last line, there is an increased inflammatory cytokines. Cytokines in response to inflammation, there are production of cytokines. This is an interleukin 1, interleukin 6 and TNF alpha. These are the cytokines produced by the system in response to infections. Not simple bacterial infections, but these endotoxins causes immunological reactions. When there is immunological reactions. And there is increases also P time, when it's prothrombin time, partial thrombin time, and also decreases fibrinogen and platelets. These are all in response to the inflammation caused by these meningococcal endotoxins. Similar things you will get in dengue also. Dengue fever, dengue, there are two types. There is dengue shock syndrome and there is thrombocytopenia. This dengue shock syndrome is due to this immunological phenomena immunological manifestations of the dengue virus. These jeopardize the immunity of the patients, and so there is endotoxins, and this is not called endotoxins, but this dengue virus causes immunological reaction, causes shock syndrome, and there is capillary leaking. Capillary leaks, and there is shock syndrome. So similar things happens. Same pathology happens in meningococcal meningitis also. So there is skin rash, in like dengue there is skin rash. This petechial rashes, hemorrhagic spots. I will show you pictures. One picture. There is petechial rashes and hemorrhagic spots. There is DIC. What is DIC? Disseminated intravascular coagulation. DIC means disseminated intravascular coagulation. It occurs in dengue also. But there is actually these inflammatory cytokines, they put the system in a hypercoagulable state. But this is a hypercoagulable state, but the hypercoagulable state is manifested in the periphery, the peripheral capillaries. This is hypercoagulable state, what the capillaries are blocked with the clots, capillaries, peripheral capillaries, they are blocked with the clots. But when their clotting process is progressing, they consume the coagulation factors. They consume because they are coagulating the peripheral capillaries, they are consuming the coagulation factors. So what scenario comes? There is a hypercoagulable state at the capillaries, there is coagulation, there is blockage in the capillaries, and in the system there is dearth of coagulation factors. So opposite factors occurs in the periphery and the system in the blood. Peripheral, there is a hypercoagulable state, coagulation is there, they consume the coagulation factor, and there is hemorrhagic manifestation in the system. So there is the two systems are going side by side, one hypercoagulable state and one is coagulation failure. So these two systems are going. This is the unique pathology of DIC or disseminated intravascular coagulations. So what you will get? You will get the capillaries are blocked. There is shock. The tissues is not getting blood, but there is at the same time there is bleeding manifestations. So these are the features of DIC. It occurs in many diseases. You will see the term DIC, disseminated intravascular coagulation. This is the basic pathogenesis of disseminated intravascular coagulation. Hypercoagulable state at the periphery and the hypocoagulable or the coagulation failure in the system. What may be? So these are the states, and you know that the increased inflammatory cytokines is there. Now this is the pictures where you see in the left side you can see the petechial patches, and there is the hemorrhagic spots in the right side. The hemorrhagic spots. These are the unique features of meningococcal meningitis. Now, if in the continued bacterial meningitis, other than Neisseria and meningococcus, another important is Haemophilus influenzae. That is also a capsulated gram-negative cocci. You know that causes also meningitis, and Listeria monocytogen is another organism. These occurs usually in elderly and alcoholic patients, age more than 50. Patient may be alcoholic and immune suppressed. And pregnancy also important cause of this Listeria monocytogen. Why more common in pregnancy, you do not know, but Listeria is slightly more common in pregnancy. But now treatment. Treatment is very important because you know when the meningitis patient comes, I have told you it is a stormy events. Patient comes with this fever, altered sensorium, neck rigidity, vomiting, etc., high fever. You cannot wait for the bacterial culture to come for the treatment of the patient. So, I am sending the blood culture, let the picture comes, or the CSF culture, then let the picture comes, then I will start antibiotic. No, you have to start the antibiotic instantly whenever you diagnose the case of meningitis by your clinical features. At the same time, you prepare for give an antibiotic and prepare for the patient for CSF examination. That is the immediate effect. You should react in this way. Give an antibiotic, protect the patient from the severe infections, and do a CSF examination at the earliest. CSF lumbar puncture and do a CSF examination at the earliest. But before doing that, you start an antibiotic. So sometimes the antibiotic is started empirically by just suspicions. What the bacteria is, we don't know. But for there is a regime. Whenever the patient comes, you will see if you suspect it is a case of bacterial meningitis, then you will start vancomycin and ceftriaxone. The reason is that it covers all the common organisms. You know, there is influenzae, meningococcus, and Neisseria meningitis. All three common organisms are covered by this vancomycin and ceftriaxone. So you start this regimen immediately. But Listeria, remember, the Listeria is not responsive to this regimen. So if you suspect it is a case of Listeria, I have told you when you suspect it is in elderly age or alcoholic, if you suspect it is a Listeria and the Listeria is common in that part of the community, then you should start ampicillin also. But in case of Pseudomonas, if you suspect it is a case of Pseudomonas, suppose you are in the nasal swab culture, you have found it is a Pseudomonas. So there is a chance of Pseudomonas is infecting the meninges. In that it causes immunosuppressed patients, particularly in diabetic patients. Pseudomonas is very common in the nasopharynx commensals. So Pseudomonas and MRSA means methicillin resistant Staphylococcus aureus. There is Staphylococcus aureus which is methicillin resistant. methicillin resistant Staph aureus. The MRSA is methicillin resistant Staph aureus, or it is a Pseudomonas if you suspect, then vancomycin should be added with, not with ceftriaxone, but with another 4th generation cephalosporin because cefepime. And you can add also, either you can add 4th generation cefepime or you add meropenem if you suspect Pseudomonas or methicillin resistant Staph aureus. This meningitis, I have told you, it is very interesting. Meningitis patient has one prophylactic treatment also. Prophylactic treatment to be given, I have told you, in a military barrack, one military has developed this meningitis. So other militaries in that barrack, they are very high chance of getting the infections. So prophylaxis to be given to the other soldiers. Similarly, in household some patient, one patient who got a meningitis patient, other family members should be protected. Particularly if the pregnant lady, they should be protected with this prophylaxis therapy of meningitis, because I have told you that is spread in a crowd. So crowd is if you know the crowd, you should protect them. They are also exposed to this. So there is prophylactic therapy for rifampicin is you do is one is rifampin, 600 milligram rifampin given 12 hourly, or you can alternatively you can use ceftriaxone, or you can use ciprofloxacin 500 also. These are the prophylactic therapy for Neisseria meningitis. So Neisseria meningitis is important catch questions in your theory prepared like this. And I have told you, when there is no bacterial culture is negative, no bacteria is there in the CSF, we call it a aseptic meningitis. There is no sepsis, means there is no culture. So it is aseptic meningitis. Aseptic meningitis, there is no growth, or there is routine bacterial cultures. What are the causes? This most commonly the bacterial cultures will be negative in viral meningitis. So it is herpes simplex virus. These are the common viruses. Virus is very important in children. Meningitis, they commonly suffer from this viral meningitis in children. So herpes simplex virus, there is varicella zoster virus. I have already told you. What you will get, usually there is some genital ulcers. Herpes they causes some genital ulcers. There is skin rashes. When you suspect this viral infections is there, you give Abscess, that will not respond to this vancomycin ceftriaxone. No, they are bacterial, they are antibacterial. So you add acyclovir. Acyclovir is causes, but this acyclovir also remind this you should be checking the renal status, because this causes nephrotoxicity. Sometimes when you are in a confused state, there is a bacterial or viral, sometimes we do a what called a khichdi treatment. Khichdi treatment give vancomycin ceftriaxone, and give acyclovir also. All these things, when you are in a mess, what is there? So because you have to treat it within 48 hours, otherwise the patient you will lose the patient. So this another group is enterovirus group. I have already told you Coxsackie virus and ecovirus. These are also common viruses causing meningitis. Usually they are commensals the lower GI tract or respiratory infections. They also causes maculopapular rashes. And measles, mumps, and if the ladies that the bacha is unvaccinated, then there is measles and mumps is also there. Yeah, have you seen recently there is a spread of this measles encephalitis in Bangladesh, because a part of the Bangladesh was not allowed to give measles vaccine child. That part of the world recently it happens, and that part of the Bangladesh the child suffers from measles. There is a mortality also. There were some casualties suffer from measles encephalitis because they were not allowed to vaccinate. Anyway, so the measles and mumps they are the common unvaccinated child you should suspect. And arbovirus infections, arbovirus, there are arthropod borne viruses, like dengue virus is an arthropod borne virus. Like dengue virus, Japanese encephalitis, chikungunya, West Nile fever, yellow fever, and Zika virus. Zika virus is also sometimes in news also, Zika virus. So all these viruses are arthropod borne. The virus is carried out by the arthropod insects. So they can be causing this viral meningitis. Tick-borne, there is not only there is a tick-borne meningitis also usually causes encephalitis. These tick-borne diseases usually cause encephalitis. They are flavivirus. These tick-borne, they carries the flavivirus and tick-borne encephalitis, also arthropod-borne but transmitted by ticks, not by mosquito, by ticks. And Lyme disease, I have already told you, it can cause, the Lyme disease is an important disease, it can cause bilateral facial palsy. Sir, there are some causes of bilateral facial palsies, like Guillain-Barré, atypical Guillain-Barré, diabetes, and this is another cause is Lyme disease. This causes bilateral facial palsy. Both the facial nerve is involved. Anyway, it's a difficult question. And Rocky Mountain spotted fever. RMS fever is the Rocky Mountain spotted fever. These Rocky Mountain spotted fevers typically produce rash. Fungal, I have already told you what fungus causes this mucormycosis. The chronic sinus. Mucormycosis was in news, was in talk during COVID period. Mucormycosis. In COVID period, we saw many cases of mucormycosis spread from the nose into the brain. The mucormycosis. So there were several cases reported in this COVID period. There were some cases of mucormycosis. Anyway, so the mucormycosis, particularly in diabetic patients, we are very much cautious in that period. If there is a diabetic patient suffering from corona and admitted in the ward, we always suspected there may be a mucormycosis. In several cases we found. Anyway, this mucormycosis is the chronic sinusitis, chronic sinusitis particularly in diabetic ketoacidotic patients, diabetic ketoacidosis, and coronavirus. We have told you during the coronavirus infections, there is aspergillosis. All these fungal diseases are treated with antifungal agent called amphotericin B. Other important causes. TB meningitis, I have already discussed, occurs in endemic area in and also in immune compromised patients. Cryptococcal meningitis, again it occurs in AIDS by acute immune deficiency syndrome when the CD4 count is less than 100. You know the CD4 prognosis of the patient, of the AIDS patients, and also the response to treatment is monitored by CD4 count in the blood in HIV patients. If the CD4 count is less than 100, there is chance of getting cryptococcal meningitis in HIV patients. Then there are other organisms like Toxoplasma gondii. It is a protozoa causing multiple brain lesions and chorioretinitis. The toxoplasmosis is also important cause in HIV patients. Toxoplasmosis. The important clue is there is chorioretinitis. Toxoplasmosis also involve the retina and chorea, and there is chorioretinitis. And lymphadenopathy, there is also lymphadenopathy. This toxoplasma treatment is very simple. You treat it with sulfadiazine and pyrimethamine. Drug-induced aseptic meningitis, there are some drugs can cause aseptic meningitis like NSAID, immunoglobulins and monoclonal antibodies. These are the drugs can cause also meningitis. So several meningitis causes are there. What are the complications of meningitis or encephalitis? These are the special complications of meningitis. Okay, so this is Streptococcus pneumoniae. It involves the cochlea and the 8th nerve, causing sensory neural deafness. So you can get this Streptococcal pneumoniae. You can get a sensory neural deafness as a complication after recovering from pneumococcal infections. They have treated with good antibiotics, but patient may develop sensory neural deafness. These are special complications like hydrocephalus. I have already told you, communicating or non-communicating due to compression of the SOL. Non-communicating means there is a SOL, there is compressing the ventricle, and communicating means there is no compression, only there is excessive production of CSF. There is excessive production of CSF also increases the CSF pressure, that can also cause hydrocephalus. So in non-communicating hydrocephalus, there is no obstruction in the flow. CSF can flow in its own path, but due to excessive production, there is pressure, increased pressure. And obstructing is non-communicating. Non-communicating means there is obstruction, the flow is obstructed, that's why there is a hydrocephalus. A simple thing is. So this hydrocephalus can occur. Increase in intracranial pressure, very important. I have told you in both the cases, if there is excessive production of CSF, there will be increased intracranial pressure, and if there is no communication due to SOL, the pathway is blocked, then again there will be raised intracranial pressure. What are the features of raised intracranial pressure? Very catch question in your exam. That is Cushing's triad. What is in the triad? That is hypertension, bradycardia and irregular respirations. These are called Cushing's triads. How the patient presents? Patient with severe headache, vomiting, in projectile vomiting, I have told you, this is a signs of raised intracranial tension. Now, cranial nerve palsies. Very important is 6 cranial nerve palsies, also called the false localizing sign. Why it is called false localizing sign? Because if there is a increased pressure in the brain, the 6th cranial nerve is the longest extracranial course. This is after coming from the meninges. I have told you it pierces the meninges. After it pierces the meninges, it takes it comes from the one side to other, a long course. Because of the long course, it is exposed to raised intracranial pressure. There is no lesion in the 6th nerve per se, but due to raised intracranial pressures, it is affected. It is compressed by the wall of the falx cerebri and get paralyzed. So, 6th cranial nerve per se is called a false localizing sign of the raised intracranial pressure. It is not involved directly, but it is the features of 6th cranial nerve palsy. 6th cranial nerve supplies the lateral rectus muscle of the eye. So, if there is lateral rectus palsy, there will be diplopia. Any muscle paralysis of the on the ocular muscles causes double vision. This causes diplopia, and also can see the paralysis. And particularly in TB meningitis, I have told you it can catch any nerve, particularly 2nd, 3rd, 4th, and 6th nerve and 7th nerve palsies are common in this TB meningitis. Now come to CSF examinations. This already I have told you CSF approach is how this is approached. This is in L3. You know that the spinal cord ends at the lower end of the L1 vertebra. Spinal cord ends. After that, there is meninges and CSF only. There is the spinal cord. Spinal cord ends at the lower end of the L1 vertebra. Okay, and all this up to the L5. There are many dermatomes. There are segments. All segments are closed within this L1. All segments are supplied within this L1. After that, there is no spinal cord. Below the level of the L1, lower part of the L1, there is only CSF and meninges. So that part is the ideal site to get your CSF, because you will not injure the spinal cord. If you do it above the L1, there is chance of injuring the spinal cord. So, so it is done to the L3, L4 spine. Pressure, I have told you, 15 millimeter CSF is a normal pressure. It should be less than 15, but it is increased in raised intracranial pressure. Color usually it is usually clear, but it may be cloudy in bacterial and maybe bloody color in herpes simplex HSV, herpes simplex virus infections. And TB meningitis is also very high protein. TB meningitis causes very high protein that also causes a cob wave coagulum. If you keep the CSF for some time, it will clot because there is a high protein content, that is called cob wave coagulum. Cell content is usually 0 to 5. If it is very much higher in bacterial meningitis, leukocytosis, they are, and protein is 15 to 45, glucose is 50 to 60. 70% of the blood glucose is more or less. In the right side, you see there is, we cannot read it properly. Anyway, this total, this is the leukocytes in meningitis. The leukocyte count is very high. Protein will be increased in all the cases. Glucose will increase, and in TB meningitis, and in TB meningitis, there are leukocytosis with predominant lymphocyte. Glucose will decrease in bacterial meningitis. The bacteria will take the glucose. Glucose will drastically decrease in bacterial meningitis, but it will decrease some in tubercular meningitis. But in aseptic meningitis or viral meningitis, it will almost unaffected. A special test you do in CSF is ADA. As you know, ADA we do it in TB meningitis. We do it ADA special test, and in TB meningitis also we should send the sample for CVNet to detect the TB bacilli. And you can, if you suspect it is a Streptococcus, you can do cryptococcal antigen from the CSF. In the Lyme disease, there is Lyme antibody index in the CSF. These are the special tests done in CSF in relation to meningitis. Now these are the few slides. Just wait. These are the few slides. You can see there is intensity of the next after CSF. After doing CSF, you do a non-contrast study, and after that you do a contrast study of the CT scan of brain. Why this NCCT study? Non-contrast study will exclude any brain abscess, but contrast study will do Then eliminate brain abscess, tuberculoma, neurocysticercosis, and toxoplasmosis. Contrast, these are the contrast enhanced lesion. If you give a contrast, the contrast the ring enhancing. This is the MRI and T2 images of the bilateral temporal lobe hyperattenuation in HSB, very important HSB1 infections that causes the bilateral temporal lobe hyperattenuations. These are the pictures. We know there is a neurocysticercosis. And neurocysticercosis, the multiple lesions. There is a white lesion inside the black hole. This is also called dot in hole appearance. Dot in hole, multiple dot in hole appearance. This is called neurocysticercosis. These are the CT scan for brain abscess. And brain abscess is also ring enhancing. No, this is a ring. This is a ring is the contrast. The ring taking the contrast much more. That is called ring enhancing. So brain abscess is the ring enhancing lesions. Here there is the basal ganglia lesions that occurs in toxoplasmosis, bilateral basal ganglia lesions. Now this is probably the last slide. This is the last slide. Some talk about brain abscess. You should know because this may come as a shortnet. And it is the spectrum of the infectious disease, not only meningitis, encephalitis, and brain abscess also comes into the spectrum of the CNS infections. That's why I kept one slide for brain abscess. You know, the brain abscess may be direct spread from mastocytitis, otitis media, very common in children, very common in children. Children suffering from otitis media and that develops a temporal lobe abscess, very common in children. You see, so there is a direct spread from mastocytitis, otitis media, there is a temporal lobe abscess in children, or there may be cerebellar abscess, cerebellum abscess also. And periodontitis, in the dental infections, odontitis, or there is ethmoidal sinus infections, that will be chance of this parietal or frontal lobe abscess. So this media, otitis media for temporal lobe abscess, cerebellar abscess, periodontitis and ethmoidal for frontal and parietal lobe abscess, usually which found in children. Multiple brain abscesses and or bilateral bacterial endocarditis. Now there may be abscess may be multiple in bacterial endocarditis. You know what is bacterial endocarditis? Endocardium is infected and there is a showers of bacteria goes to the blood. At a time there have been showers of bacteria goes to the blood, and if there is a breach in the blood-brain barrier, there will be multiple abscesses in the brain. So important cause of multiple abscesses in the brain is bacterial endocarditis at viridans or Streptococcus viridans or Staph aureus. These are the common organisms for bacterial endocarditis. This Streptococcus viridans and Staph aureus. Staph aureus. These I have not mentioned these are common organisms in your uterine bacterial meningitis, but this may be the common organisms as is common organisms of bacterial endocarditis. In that case, this organism can go into the brain and cause multiple brain abscess, and also pneumonia is a risk factor for pneumonia. And important brain lesion is neurocysticercosis. This part is very common in our this part. You get many cases of neurocysticercosis. I have shown you the pictures of neurocysticercosis. This upper one is a phase of neurocysticercosis. There is a multiple lesion, ring enhancing, and also there is a dot in hole appearance. So neurocysticercosis bilateral is the bilarval stage of the tinea solium. Tinea solium is the organism. The larval stage they stay in the brain. Is a pork tapeworm. It is also called the pork tapeworm. Major cause of acquired epilepsy in endemic area. It is a major cause of epilepsy in endemic area. This is, I have told you what is the multiple ring enhancing lesions with a hyperintense nodule, scolex. The scolex is inside the inside that gives a hole in dot appearance. I have shown you the pictures. Hole in dot appearance. This is usually treated by albendazole for 2 weeks and also corticosteroids. But not mentioned in this is the, there is scrap typhus. Scrap typhus also we get many patients of in sometimes we got it. Nowadays we are seeing it little less, but at one time we got many cases of scrap typhus and encephalitis. Scrap typhus, it is a rickettsial disease. Scrap typhus is caused by a rickettsial disease, and it is caused by bitten by a mite. It is not tick bone; it is a mite bone. So if you get you can get this MCQ answer, which this scalp typhus is a mite bone. It is a rickettsial disease. What you call it? It's a mite bone rickettsial disease, and you get the mite bite. Eschar formation in anywhere in the body. there is a scar formation, and the child comes with the features of encephalitis. In our many cases we will find nowadays in Purulia, Bankura and rural areas, there are several cases of scrap typhus. They come with the features of encephalitis, meningitis. They have a scar formation in there, and if you could do an antigen test, you will get there is a rickettsial antigen is present in the CSF.